Release tension.
It's actually to change a muscle's resting length. Here's another muscle energy technique question. All right, so the massage therapist is performing muscle energy techniques on a client with normal muscle strength. What amount of strength exerted by the client is required during the contraction for the muscle energy method to work? No greater than 75% of strength, no greater than 50% of muscle strength, full muscle strength, no greater than 25% of muscle strength. What do you guys think?
Full muscle strength.
Okay, can I get somebody to get another guess?
Hold on, I'm just trying to go over the question.
Okay, all right. Well, let me read it to you again. The massage therapist is performing muscle energy techniques on a client with normal muscle strength. What amount of strength exerted by the client is required during the contraction for the muscle energy method to work? No more than 75, no more than 50, full muscle strength, or no more than 25.
No more than 20.
I'm gonna say no greater than 50.
Okay. The answer that AMTA says is 25.
Okay.
So you guys keep those in mind. Muscle energy technique is to change a muscle's resting length, and it involves no greater than 25% of the muscle strength.
Okay.
All right. Let's see. Which movement will shorten the fibers of the rectus abdominis? Is it extension, flexion, rotation, or pronation? And the answer is flexion.
Mhm.
I should have asked you guys, actually. I should have asked you guys. So
short fibers of the rectus abdominis.
yeah, so if it's the rectus abdominis, is that the front or the back?
The back.
Front.
That's right. That's right. And of the muscles in the muscles in wait a minute. Did you say the back?
I said the back.
Yeah, no. Which muscles shorten the fibers of the rectus abdominis? That's actually the front.
Okay.
Right. So in that area, it's the rectus abdominis in the front, and then it's the spinal erectors in the back, or the quadratus lumborum, or the back muscles in the back.
Okay.
All right. So that would be flexion that shortens the muscles that are in the front, or shortens the muscles of the rectus abdominis. It helps to think about the surface. If you guys need to see anything, like if there's a question that just has the muscle written, or you want to see an example of something, and it's not here on the slides, you just let me know. All right. Okay. And what we see here is an anterior view of the muscles of the leg. This yellow one over here is just a blow up of the muscles on the top. Okay. So what we have is, we have the quadriceps muscles in the front, and we have some of the adductors visible. We also have the iliopsoas visible, which is inside the ilium, right? And I wanted you guys to know that the whole leg is called the lower limb, right? And the whole arm is called the upper limb. And most of you know that, upper limb, lower limb. The leg, however, unlike the arm, has a lower leg. So it's the lower limb involving the femur, and then the lower leg, which involves the tibia and the foot, lower leg. And in the lower leg, you have muscles that we've covered, including the tibialis anterior muscle. In the back, there's the soleus, which is the deeper muscle of the calves. And then the more shallow muscle is the gastrocnemius. So you have the tibialis anterior, the soleus, and gastrocnemius, and they're going to ask you those for sure. We're going to look at the upper leg in a minute. But I also wanted to show you guys two muscles that I haven't mentioned that you probably have heard of or probably know. The first is the extensor digitorum longus. And you can remember the extensor digitorum longus because it's wedged between the tibialis anterior and the peroneus longus. The peroneus longus is also a muscle which I don't think we've mentioned explicitly, but it is important. So the peroneus longus is also called the fibularis. And the peroneus longus attaches to fibula, which is why it's called the fibularis. Right, so if you look at the peroneus longus on the side and the tibialis anterior in the front, wedged between the two is the extensor digitorum longus muscle. And if you can make sure that you know that you know those muscles, because they are important. They're probably going to ask you about those. I guess I should tell you that extensor digitorum longus. Let's look at the name extensor digitorum. What motion do you think extensor digitorum longus does? Does it do extension or flexion?
Extensor.
Yeah, and when it says digitorum, do you think it's talking about the toes, or is it talking about the whole foot?
The toes.
That's right. And when it says longus, obviously it's referring to the length of the muscle and the tendon combined, the length of the muscle and the tendon. Don't worry, they're not going to ask you. They're not going to ask you if the longus refers to the length of the muscle and the tendon combined. I just wanted you to know that. Okay. But it is very long. The tendon does go down underneath the bottom of the foot, the sole of the foot, and it attaches, I think, only to the big toe, but it's a long one. It extends one of the digits. No, it goes over, not under. It goes over. Okay, and then the peroneus longus muscle. The peroneus longus, as well as its little brother, the peroneus brevis. The peroneus muscles, they're on the lateral side of the foot. So what movement do you think they would do?
Abduction.
Abduction. Yes, that's
like-
correct.
Okay.
Yes, it would do abduction. Yes. Okay, what else? Yeah, just make note of this.
That, like, is that our only choices? Or could you say like dorsiflexion?
You mean, does the peroneus longus do dorsiflexion? I think it probably,
Yeah.
I don't think it's a prime mover. I think it probably is a synergist. It probably helps. But
Okay.
if they ask you about dorsiflexion, they're not going to omit the tibialis anterior.
Okay.
Okay, and if they ask about abduction, which also could be called eversion, right?
Okay.
If they ask about abduction, they will definitely want you to answer peroneus longus.
Okay.
They're not going to omit peroneus longus for abduction. Okay, and then just make note of this triple tendon here. This tendon is called the pes anserinus, or pes anserinus, and anserinus means duck, and pes means foot, so it's the foot of the duck. So it's shaped like a foot, and it's shaped like the foot if you are a duck, and it's made up of 3 tendons, and they may ask you this. You know, there's so much to cover that by the last 2 classes, I'm just hoping that I'm going to go over the stuff that they're going to ask you, right? So I think a random presentation is good, because it's anybody's guess, and even in the same room, it's anybody's guess. Like if 2 of you go in there, you're going to get 2 different tests. They're not going to give you the same exam. They're going to randomize everything. But the pes anserinus, see, it looks kind of like a duck's foot. See this part here? Like the ducks have like a paddle on them, right? All right, and then it's made up of the semitendinosus muscle, which is one of the hamstrings, one of the abductors, or one of the quadriceps muscles, semitendinosus.
The hamstrings.
The hamstrings, that's right. And what's the nickname for the tendinosus and semimembranosus? For short, we call them what? The
Semi-sisters.
The semi-sisters, that's right. Semi-sisters are doing it for themselves. And then on the other side of the hamstrings, you have which muscle? It has the word femoris in it. So there's 4 bellies for the for the hamstring, there's 3 actual names. Semisisters are 2 of them, and then the other one is okay, we'll look at those. So in the quadriceps in the front, you have the rectus femoris. In the middle and in the back, you have what femoris? Biceps femoris.
So the quadriceps, the rectus femoris, and in the back you have the biceps femoris.
Biceps femoris, yes, yes. We
Okay.
will look at those in just a moment. Okay, so the pes anserinus is made up of the semitendinosus tendon and the gracilis tendon. The gracilis is one of the abductors, adductors, one of the adductors. And then the sartorius muscle, which does both adduction and flexion. So here's the sartorius, and it does a little bit of, it does mostly flexion. It also does external rotation, and it's a synergist with abduction, synergist with abduction. But if they ask you, the sartorius is part of the flexor group. The gracilis is part of the adductor group. The semitendinosus is part of the extensor group. So let's finish up looking at the muscles in the front, and then we'll look at some of the muscles in the back. All right, so in the front, you have the 4 muscles of the quadricep group, and that's the vastus what on the lateral side. So you have the lateralis and the medialis for the vastus muscles. So is this the vastus lateralis or medialis?
That's the
Vastus.
yeah, not the medialis. 'Cause it's
Lateral.
more middle, right?
Lateralis. There is a middle one called the vastus intermedius, but this is the lateralis because it's on the lateral side.
Mm.
Lateral side. Let's see. Can someone, let's see, can someone tell me, how can you determine that this is the lateral side when you look at this diagram?
Because it's away from the body.
Okay.
Away from,
Okay, now that is not bad. That is not bad, but it's not accurate enough. So when you're looking at this, is this Jessica?
yes.
When you're looking at this, Jessica, you know almost instinctively that it's away, that it's the outside of the body, right? Probably
Right.
just by looking at the shape of the muscles and the contour of the muscles. But if you were to look at the bones, because the bones don't change that much person to person, drawing to drawing. So if you were to look at the bones, how can you tell that this is the lateral side?
By the front of it.
Okay, so if you look at the bones, this bone here, for example, it curves downward. It curves downward and inside, downward and medial.
Okay.
Do you recognize that as the ilium?
Yes.
Okay, does anybody not recognize that as the ilium? It would be a good use of our time if we looked at the whole ilium if you don't recognize it. Okay, so it would be fine. So speak up. So this bone here is curving from top to bottom, curving toward the inside.
So that's how you would tell that it's or the lateral.
That is how you tell that this surface is lateral and this surface is medial,
Okay.
assuming none of the muscles are labeled. Okay, here's another way that you can tell. If you go down to the bottom, you see where the big toe is. Can you guys see that?
I see it. Yep.
Can anyone not see that? Yeah, the big toe. Also, if you look at the vastus muscles above the knee, you can see that there's the vastus medialis, which has a bigger bulge and whose border is lower than the vastus lateralis. the vastus medialis is unique because the bulge of the muscle, the gaster, the belly of the muscle, is larger at the bottom, bigger at the bottom. And for the vastus lateralis, it's more gradual and it's bigger in the middle. And then also, if you can recognize the pes anserinus is always on the inside. Okay, does anyone want to look at any of those structures that we mentioned? Does anyone want to look at any of the bony structures?
I do.
Okay, so let's also touch as we're doing this. So as you're looking at the ilium on the page, I want you to start here and touch the ASIS, the anterior superior iliac spine, okay? This is the anterior superior iliac spine. This is the top of the drawing right here. Thank you. It's the top of the drawing right here. And the drawing goes down like this. It's curving down and toward the inside. It's going like this, right? Notice that it's not a strict curve. There's like a concave curve and then a convex and a concave and a convex and a concave, and then you're at the middle. Right? And in this drawing, it's just curving like this, right? That's because this is actually not all the bone is visible. You can see part of the bone here and part of the bone here, but it doesn't matter, okay? Because this is a perfectly reliable way to use it. That's because this is not actually the bone. It's the ligament that connects them. So it's a ligament that goes from the ASIS down to, what structure is that? Probably the most medial aspect of the pubis. But let's finish with the pelvis and then we'll move on a little bit. Okay, so touch the ASIS, right? And then go to your belly button and then go down to the pubis, find the pubic bone, and then walk your two hands together. So like this, all right, just so that you can feel the inguinal ligament, and maybe you can feel some of the bones of the pelvis. Like I can definitely feel my pelvic bone between the ASIS and the pubis. I definitely can feel that. So that's the front, right? And then if you start to go from the ASIS backward, you just have to fold your hand like that, and you can feel the top of the ilium. Keep going back, and then you'll feel this bone back here. There's two of them on either side of the sacrum.
Okay.
You'll feel these two bony bumps, and that's the posterior superior iliac spine.
So the posterior. Okay. I was just making sure I knew right where
Yes.
it was for sure.
Yes, you should, because if you can get it right now in class, you can practice it accurately. Okay, has everyone found the anterior superior iliac spine and the pubis? Did everyone find that? Did anybody not find it?
Can you show me again where that would be? I think I got it, but I just want to see where you're pointing at on the front side.
So to find the anterior superior iliac spine, you would simply touch the most prominent bump of the pelvis, and it is the bump which is a little bit below the navel, right? So here's my navel. We have our navels in about the same place. Only the clothing changes. Your so-called waist is higher than man's clothing, right? So don't let the waistband fool you. So you go to the navel, you go over to the side, and then you simply go down until you hit that big bump. And that big bump, that bone is the bone that would press into the ground if you were laying on your belly, right?
Okay.
If you're thin enough, and it's the first bone that you feel if you simply slide your hand down.
Okay.
Below the navel. So there's the ASIS, and you can get that bone there, right? And then you go from your navel and you move your hand down until you feel the pubic bone.
Okay.
Right? You should be able to feel the bone pretty easily. And look at the distance between top and bottom on my pelvis. Right? It's like this, my pelvis is like this long between the ASIS and the pubis. So yours should be should be about the same.
Okay.
Has everybody got the pubis and the ASIS?
Yes.
All right, and please speak up if you don't have it, okay? Now you simply walk your fingers going a little bit cross fiber so you can feel the pubic bone, right? I can feel mine here under my left hand, and I can feel it a little bit under my right hand. Yeah, I feel it. Doesn't feel good to press the bone, but now I know where it is. All right, and then go back up to the ASIS, and then you just take your hand and you fold it backward like that. Just take your hand and you fold it, you reach your thumb back, fold your hand back. And then your hand is sitting on the curve of the ilium, curve of the ilium. Does everybody have the curve of the ilium?
Yes.
All right, now while we're here, right under this curve in this area, this is where you find where your pocket is, or approximately where your index finger starts going down. It's where you find the tensor fascia lata. And then behind that, you find this seashell shaped muscle, the gluteus minimus. And then some of the glute med will wrap around and attach like that. We can look at those muscles if you want to today. Anything today is fair game. You guys want to spend time looking at bones and muscles? We can do that. You want to go over recently reported questions or something else that's challenging? I'm down. All right, so then you go from here. Now slide your hand back until you find the PSIS. The PSIS is a bony protrusion, and it's part of the ilium. And if you cannot find that, an easy way to find that is to go to your spine, go down to where you think the bottom of your spine is, right? So you find your sacrum, and then you go over a little bit, and it'll be right there between the bottom of the spine and the sacrum, a little tiny bit higher, quarter inch higher. But if you can find the L5S1 junction. Can everybody find the L5S1 junction?
Yes.
Is anyone not finding their L5S1? Okay, great. So you find your L5S1. You got your thumb on the ilium, or what you think is the ilium. You slide your finger from L5S1 over, and right about where your thumb is, right about where that finger ends, you'll find a kind of a modest bony protrusion, not as prominent as the ASIS, but you'll find kind of a modest, smaller version of the ASIS in the back, and that's the PSIS, posterior superior iliac spine. Right now, because we have proprioception, we can just put our thumbs symmetrically on both PSISs, and right in the middle is the sacrum. So just pivot one of your hands and place it flat on your sacrum. So now you have the PSIS on one side, you have the sacrum in the middle, and then you have the PSIS on the other side. All right. Is anyone lost? Okay, good. So now from there, you bring your hand down. I'm standing like in a lunge. If you're in a seat, just lift your butt up out of the seat. So now you bring your fingers down, right, alongside of the sacrum. This is your SI joint, by the way, between the ilium and the sacrum. So the sacroiliac joint. Bring your fingers down along the SI joint on one side of your pelvis, and then feel for the bone down there. And what you're feeling now is the ischium. So you have the ilium on the top and the ischium on the bottom. And the boniest protrusion, when you start to sit down, the one that actually presses onto the seat, that's the ischial tuberosity. Now, is everybody with me? Does anybody not feel their ischial tuberosity? I think I heard Rosie.
Yes, I felt it.
Okay, great. Major win, guys. Good use of our time. Truly. Okay, so while we're palpating, let's look at the lateral let's feel some of the muscles, and also look at the lateral rotators. And I will just put up a picture of the a picture of the piriformis muscle. Okay, so how do I, oh yeah. Yeah. Okay, so here's the piriformis. There's the piriformis right there. Now they're probably going to ask you about the piriformis. Don't sit down yet. Right? Now here's the sacrum. So I want you guys to touch your own sacrum, right? So that's the hand right in the middle. It's the hand right in the middle. All right. Put your thumb on your PSIS. So hand on the sacrum, then there's the PSIS. And then right under bring your fingers over, and right there, you'll be feeling part of the belly of the gluteus max. And then if you go a little bit deeper inside and go cross fiber and start to go diagonal down towards your greater trochanter, you'll be feeling part of the fibers of the glute med. It's my greater trochanter right here. Here's the PSIS. Yeah, it should be up and down diagonal, not, I don't know if I said that right. So up and down diagonal, you can feel the glute med. If you want to feel the glute med moving, you simply laterally rotate your knee, laterally rotate your femur, right? So I've got my hand here on the glute med. Here's the sacrum. Here's the PSIS, right? Bring the fingers in a little bit. Glute med should be right there. Right, and then laterally rotate the knee. So from the front, I'm going like this with my leg. And I can feel that muscle contracting. With the same movement, you'll feel the piriformis. So if you bring your fingers down just a little bit, and then you have to press a little more deeply because the piriformis is a little more deep than the glute med. And the same movement, external rotation of the femur. You'll feel the piriformis muscle. Now, did anyone not find the piriformis muscle? You should definitely feel the piriformis shortening as you externally rotate. Is everybody good with that?
Yes.
Yes.
Okay, is anybody finding this concept that we're doing today unsatisfying or, not good? All right. Please speak up if there's something specific that you want to cover today. So those are the muscles of the I usually just call it the posterior because I don't want to say back. All right, now let's go back around to the front. Put your finger on your ASIS. And if you want, you can put another hand or finger on the pubis. And if we look at the inguinal area, so they're showing hernias, all right? So I'll be more specific, inguinal ligament, all right? Remember this one? So here's the inguinal ligament. There's a bone here, which is, what bone is that? Is that the ilium, the pubis, or the ischium?
The pubis.
The pubis, that's right. And the one in the front, the name of this one is what? Anterior superior what spine? Anterior superior what? Iliac or ilium? Iliac. Iliac. So this is the ilium, not the ischium.
Yeah.
So anterior superior iliac spine, pubis or pubic bone, and then between them is the inguinal ligament. So the inguinal ligament looks like here's a good one. I hope you can see that. So this ligament is often drawn as just like a cable, right? And it connects the pubis with the ASIS. So if you're looking at the landmarks, you know that this is either the inguinal ligament or the pubic bone, inguinal ligament or the ilium. And you can tell because this bump is higher than this bump, and there's a curve. And even if you look at the regular, pubic bone, even though it's got this concave convex structure, there's a net curve downward and in, downward and medially. All right, so we got those bony landmarks for the pubic bone, the ilium and the ischium and the ischial tuberosity in the back. We looked at the inguinal ligament. We talked about the glutes, the TFL. This one is labeled right here, the tensor fascia lata. You ever want to find the TFL? Put your hand in your pocket. I mean, these things are all written by people who wear certain kinds of clothes. So they say, put your hand in your pocket and you'll find the pocket muscle right underneath where the pocket is. And it definitely is there on my pocket. And while we're here in the area, before we go back to the other like non-anatomy, non-kinesio questions, let's look at some of the other muscles, right? And we can feel these too. So in the adductor group, they have all the adductor muscles, or I think most of them, because the semitendinosus acts as kind of a synergist. But they have the adductor magnus, which is you definitely want to be familiar with that. The adductor brevis, and then they have the adductor longus. And what do these three muscles all have in common in the name? What do they all have in common?
Adductor.
Adductor, right? Adductor, yeah.
Mm-hmm.
So you have the adductor group, they're all right up next to each other. And then over top of them is another muscle that's part of the adductors, the pectineus, which is right here. And then below the adductors are the gracilis muscle. Remember the gracilis, that's part of the pes and serinus, right? So here's the gracilis. And in front is the sartorius, and in back is the semitendinosus. So here's the gracilis muscle. Right, and it attaches down below the knee on the tibia. And that's the pes and serinus, So if they were to ask you which of the following muscles, I'll do it a couple ways, okay? 2 ways. So which of the following muscles is part of the adductor group? Is it the gracilis? Is it the sartorius? Is it the tensor fascia lata? Or is it the iliopsoas? What would the answer be? Gracilis, sartorius, tensor fascia lata, or iliopsoas, which is part of the adductor group?
The gracilis.
The gracilis, correct. Okay, and which muscle is not part of the adductor group? The gracilis, the pectineus, the adductor magnus, or the tensor fascia lata?
The tensor fascia lata.
Very good. Does everybody agree with that?
Yes.
Okay, question for you. You probably don't know this, but let's look at it while we're here. I want to ask you about the obturator externus, which group it's a member of. If you look at the piriformis muscle right here, you can see that in the drawing they have this dotted line and the muscle goes clear. And why is that? It's to show the muscle is where?
It's underneath the bone.
Yes, it's underneath. It's underneath, or it's in the posterior, more anatomically correctly, Rosie. It's in the posterior.
Okay.
Yes. And we're looking at the anterior. Okay, and notice there's a dotted line here with the obturator externus. So part of the obturator externus is attaching to the same muscle, the femur, the same bone, the femur, and it's in the posterior. So the obturator externus, what group do you think it's part of? If it's attaching in the back of the femur, like the piriformis, and the piriformis is an external rotator or a lateral rotator, which do you think it's a part of? The lateral rotators, or is it part of the adductors?
Adductors.
Yeah,
So Khalees, let's look at where the adductors attach. Let's look at where the obturator externus attaches first, right? We established that it attaches to part of the femur, and this dotted line means it's attaching where, Khalees? The anterior or the posterior part of the femur?
Anterior.
The dotted line means it's attaching to the posterior.
Okay.
Posterior, right? And look at the piriformis up here. See, there's a dotted line when it goes back behind on the posterior aspect of the ilium. It's dotted line there. So can you see that the piriformis muscle is on the posterior?
Yes, I can see it.
And can you see that the obturator, that a good part of it is on the posterior as well?
Yes.
Okay, good. So, and they both attach to the femur. What part of the femur do they attach to, the anterior or the posterior part of the femur?
The posterior.
Yes. And are they attaching a little bit? We'll get a little bit more specific, which is challenging because you're not looking at the posterior where they attach, you're looking at the anterior. But do they attach to the lateral aspect of the femur, or do they attach to the medial aspect of the femur? The piriformis and the obturator, Khalees.
The latter.
The lateral, yeah. So if a muscle attaches to the lateral aspect of the femur, what is it going to do to the femur? Is it going to turn the knee out, external rotation, or turn the knee in, internal rotation?
Out.
That's correct. So it would be an external rotator, which would put it on the back surface of the body.
Okay.
And then because in order to attach to the side and the back and rotate it externally, it has to be in the back of the body. And then if you look at the attachments of the pectineus, what aspect of the femur does the pectineus attach to? How would you describe this aspect of the femur? So use the words anterior, posterior, medial, or lateral. Is it anterior or posterior?
anterior.
Yes. Khalees, please. Do you see that it's
Oh,
anterior?
I'm sorry.
That's okay.
Anterior.
Yeah. And is this the medial or the lateral aspect?
Medial.
Medial. So if it's a little bit on the front and on the inside, which way is it going to pull the bone when it contracts?
Anterior.
Yes, it will pull it anterior a little bit. Right.
Oh, medial.
Medial, that's right. It will adduct. It will adduct. And you can see that attaching on the front doesn't make it a flexor, but allows it to keep the leg in the front. Attaching to the inside, the medial aspect allows it to strongly or very clearly adduct or move it medially. Same with the gracilis muscle. Look at the attachments. Rosie, if you look at this gracilis muscle right here, what you see is attachments on what, the medial or the lateral aspect of what bone is this here? I know
The
you know.
medial of the femur.
This is the tibia.
Tibia, tibia.
Maybe you can't see the cursor. This is the tibia. Yeah. And I always say, fibia and tibula, and I say humerus when I mean femur. And, you're mixing up bones.
Yeah.
I mix up entire limbs. So we have the medial side of the tibia, and then it inserts, or it originates or attaches at its other end to where? What is this? The pubis, the ischium, or the ilium?
The pubis.
The pubis, yeah. So if it's on the pubis, which is more medial, and it attaches to the medial aspect of the tibia, which way will it move the leg when it contracts? Adduction, abduction, flexion, or extension, or rotation?
It's abduction.
AD,
B.
adduction. Why did you say AB?
Because I'm swinging my legs outward, and I'm trying to feel the movement of it.
Okay, we will do that. I like that you have the kinesthetic portion, but let's finish with the didactic or the visual first, okay? So
Okay.
Rosie, if you look at the fibers of this muscle, they're going this way. This is a muscle with parallel fibers.
Okay.
All right, it's not a pennate muscle or a convergent muscle or any of those, all right? The fibers are going this way for the gracilis muscle. So if they contract, if they shorten, they're going to draw this end, the tibia attachment end, towards the pubis attachment end. Can you visualize that?
I'm going to have deflection.
It's going to draw the tibia
Tibia.
it's going to draw the two
Pubis.
knees towards each other.
Media.
Yes, medial. Can you visualize the muscle shortening would bring the knees together? Not quite.
Yeah, kind of. Yeah,
Okay.
because you kind of feel like a squeezing inward.
Yes, yes. And to feel, I'm going to stand up because I don't have the mobile camera. So to feel the gracilis muscle, there's several muscles in the area and it's a thin muscle, so it's not always easy to find. But if you look for the big bump on the inside, that is the vastus medialis, you look for that big bump and you go off of the bump. So if I give myself some resistance and contract my vastus medialis, right? You see this outline of the vastus medialis? You go to that medial border and then you go just a little bit further in and then come up. So you're touching like the inside, almost the inside of the thigh. And then you squeeze your knees together and you should feel the gracilis muscle contracting. You may need to go, I need to go just like walk my fingers 1/4 inch back a little more. And it's right under the skin. You should feel it really, 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 really clearly. It's right under the skin. It's a thin muscle, about 1/2 inch wide from anterior to posterior. It runs like this on me. Can you guys feel that?
I can feel it.
Okay, can anyone not feel it? Awesome. Okay, now walk your fingers back just a little bit more and you'll be feeling the semitendinosus, semimembranosus. And now squeeze your knees together and feel how those contract. Yeah, and now also push your heels into the ground so that you're actually flexing your knees and you'll feel the semimembranosus, semitendinosus contracting even more. And since we're here doing this, come back up to your ASIS, find your ASIS. And let's find the sartorius muscle. So come down directly straight from the ASIS, just about 1 hand width. So right about here. So come down here. Right, and put 1 hand on top. And then see if you can find, going cross fiber like this, see if you can find this S-shaped, how's it shaped? This S-shaped muscle, the sartorius muscle. All right, see if you can find that. You may or may not be able to find it. Okay, and if you cannot find it, I'm going to switch sides, okay, because this one has the knee that's uncovered. Start to flex your hip, so lift your foot up off the ground, flex your hip, and now turn your knee out to cross your foot over your knee, and you'll feel the sartorius popping out under your lower hand. This position with the knees crossed is how old-fashioned tailors used to work when they were stitching. Right, so this is called the tailor's muscle. Does anybody not feel the sartorius? Does everybody feel the sartorius?
Yes.
Yes.
All right.
Yeah.
All right. Awesome. Okay, so and then the adductors, we might as well do it, right? The adductors. All right, so we got done with the sartorius. We did the gracilis muscle and we did the semis. Now I'm on the gracilis. So I'm going to come right up to my groin. Here's the inguinal ligament right where my thumbs are. And so I'm coming down from the inguinal ligament right up to the groin. And I'm simply going to bring my, it's like the meat of the adductors. It's very easy to find. I'm simply going to start bringing my knees together, and right away, even without any resistance, I can feel the muscles contracting. You guys feel the adductors? Does anybody not feel the adductors? Okay, good. So last one, let's do this iliopsoas fibers. So if you look at the, I'm sorry, look at the drawing first. You have the psoas, which attaches to the spine, comes down under the inguinal ligament, and then inserts onto the medial aspect of the femur. You also have the iliacus muscle, which goes from the inside of the ilium. It comes down and inserts also to the medial aspect of the femur. Together, these two muscles form a third area of the muscle, which is called the iliopsoas. It is regarded as a third muscle. So it's the psoas, the iliacus, and the iliopsoas, but they're not going to ask you that. Is it a third muscle or is it just an area? They're not going to ask you to differentiate. But in order to find the iliopsoas, which is part of the hip flexor, you simply go from the ASIS. You go from the let me do it this way. You find your ASIS, and you come down till you feel the tendon. It's just right below the tendon, right below the ASIS, right? So once you feel the tendon, you take your other hand and you go toward the inside a little bit, right? I'm like just off my thumb, and press. You may or may not feel a pulse of the inguinal artery over near your pinky. And the iliopsoas fibers are going to be down below the ASIS, a little bit medial, right? So to feel that muscle, to feel the iliopsoas, a good way to do it is similar to the sartorius, because the iliopsoas functions to flex, but also to externally rotate. You simply raise your knee, so you flex your hip, and you'll feel those muscles starting to contract right away. You can also turn your leg out a little bit and they'll also start to contract. And there's two big tendons there, all right? There's the iliopsoas, and if you bring your thumb, the thumb that's marking the ASIS, if you bring that straight down, same level as your other fingers, your iliopsoas fingers, you'll feel a thicker tendon, and that's the tendon of the quadricep. That's the tendon of the rectus femoris. All right, so you have the rectus femoris under the thumb, and then you have the iliopsoas muscle on the inside. Thank you. So to me, that's really clear. Now, is it unclear to anyone? Please speak up if it's unclear to anyone. Okay, Dominique.
Yes.
Good morning, Dominique.
Good morning.
If I ask you which one is which muscles make up the hip flexors, what would you say? Are you reading the muscles?
I am.
Okay, so let me give you a choice then. So from memory, which ones would you say? Would it be the psoas muscle? I'm not going to get too tricky. Would it be the iliopsoas muscle and the adductor magnus? Would it be the iliopsoas muscle and the vastus medialis, the iliopsoas muscle and the rectus abdominis, or the iliopsoas and the rectus femoris?
The the iliopsoas
Yes.
and the is it the adductor?
No.
No.
No, let's look at the attachments, okay? So the AB ductor,
Is the rectus femoris?
it's the rectus femoris, yes, yes,
Okay.
it's the rectus femoris. Okay, so the hip AB ductor, let's see. Okay, so the AB ductors are on the outside, first of all. All right, and we're talking about the ones that are right below the ASIS. Okay, so if you look at this skeleton, you have the spine. Always get oriented, right? You have the spine and the ribs. And then you have this hip bone, the ilium. I can see a sacrum in the back. Right, and then there's a femur. So we're looking at the lateral side of the body. And the AB ductors are on the side, and they attach up along the ilium, and they extend down onto the femur. So you have the tensor fascia lata on the side, and then the gluteus medius and gluteus min all on the side. And then if you look at the if you look at the muscles of the quadriceps group, starting with the rectus femoris. Here's the rectus femoris without any of the other muscles. You see that the rectus femoris attaches below, it attaches to the ilium, it attaches to the pelvis, which is what we want, right? Not all of the quadriceps attach there. All right, so it attaches to the pelvis, which makes it capable of moving the leg into flexion, the femur into flexion, while the pelvis is stable. And it's below the ASIS. See, here's the big bump of the ASIS. Here's the trajectory going down and medial toward the pubis. And about in the middle is the attachment for the rectus femoris. So you have the rectus femoris attachment on the pelvis below the ASIS. And then you have the iliopsoas muscle attaching further into the pelvis, the iliacus attaching on the inside, and the psoas attaching to the spine. In any case, these two attachments, the iliacus and the psoas, they are very stable compared to the femur. So they're going to move the femur, and the other end is going to be stable. And these are I believe underneath. I'm sorry, I don't remember if they're under or over the tendon of the rectus femoris. The rectus femoris muscle would be it'd be right here. Right here. So on the other side, that'd be right about there on the bone. So it probably it would have to be under the iliacus muscle. So the rectus femoris would come down, you'd feel the tendon here. The iliopsoas, you'd feel a little bit on the inside. So ASIS, come down and inside for the iliacus, come straight down for the rectus femoris. Rectus femoris, here's the ASIS, come straight down for the rectus femoris, come down into the inside for the iliopsoas. The iliopsoas attaches here. The fibers come from the ilium, they come down and attach there on the inside of the femur. So one more time, Khalees, just seated, find your ASIS. Find your ASIS and come straight down. Come straight down off the ASIS and then put a second hand on the inside of those fingers. All right, and now you should feel two distinct bands, two different bands, one under your fingers on the outside, one on the fingers on the inside. And lift your foot off the floor. And you should feel those tendons popping out pretty clearly. You feel those like two bands there? If you can't feel them, go cross fiber with your fingers. You feel them, Dominique?
I do.
Good, excellent. Okay, I think that's a major win. Does anyone else have any questions about that? The hip flexor group. Let's look at the attachments of the other quads. The vastus lateralis, vastus medialis, and vastus intermedius. This one's kind of weird, but I think it's actually good. Wow, how strange looking. Okay, so this is without. No, it's too weird. It's too strange. Let's try this one. Yeah, this is good. So you have the vastus lateralis on the outside and the vastus medialis on the inside, right? Over here on the patient's right, you have the rectus femoris muscle. And over here, the rectus femoris muscle has been removed. They cut it off and they removed it. And this in the middle should be the vastus intermedius muscle. I don't know why it's shown as like so tendinous. Maybe there's like a fascia that covers the vastus intermedius, or maybe it's more fascial or more tendinous than most muscles, but I'm not used to seeing it white like that, but that's okay. And the vastus lateralis, vastus intermedius, and vastus medialis. Lateralis, medialis, intermedius, lateralis, intermedius, medialis. Those three vastus muscles, they don't attach to the pelvis. They don't have the stability of the pelvis. They attach to the femur, the leg bone. So if they attach to the femur, what bone are they? What bone are they depending on for stability, or what bone are they not moving? If it attaches to the femur, does it move the femur bone? Okay, let's look at the other end. The other end attaches to the tibia. All these three muscles, actually including four muscles, including the rectus femoris, all these four muscles, they form thick tendinous sheaths that form like all these tendons, the prepatellar tendon, the patellar tendon, right? And they insert onto this bone down here, the tibia. And in your mind, hopefully you can visualize there's a joint right below the patella, right below the patella. See this bone right there? That's the kneecap, the patella. So they're going to move this bone down here, the tibia. They're going to move the tibia. So the vastus lateralis, the vastus intermedius, the vastus medialis, their job is to extend the knee. It's to move the tibia. They're not going to move the femur because they attach, specifically they originate, they attach on the femur. They attach on the femur. The rectus femoris, on the other hand, the most shallow of the quadriceps, attaches to the pelvis, and then it has attachments to the tibia. You could say that it has fascial or soft tissue attachments to the rectus femoris because it lays over top of the vastus muscles. And it's called rectus femoris, so it has an action on the femur. So it pulls the femur, moving primarily this joint. You can also see that it contributes to knee extension. So it moves the knee forward. Who is confused? Is anyone confused?
I am.
Okay.
I'm confused too.
Okay. So if they ask you which of the quadriceps attaches to the pelvis, what do you say? Rectus femoris or one of the vastus muscles?
Rectus femoris.
That's correct. And if it says true or false, all 4 quadricep muscles, the rectus femoris and all 3 vastus muscles are knee extensors. Is that true or false?
True.
It is true. Yes. So what are you confused about? Okay, so let's look at the kinesthetic portion. Right now, you can do this seated, but it'll be clearer if you do it standing. You have the ASIS, right? Here's the ASIS. And down below the ASIS is the rectus femoris muscle. And then off to the sides are the vastus lateralis, vastus medialis. Right? So let's just go from the ASIS and come down a little bit onto the muscles. Right? Come down a little bit onto the muscles. And now let's do hip flexion first. So you simply flex the hip, right? So just lift your foot up, right? Lift your leg up. You feel that muscle popping out?
Yes.
Okay, now take your other hand and move it down below your knee. Move it down to below your knee. All right, I'm sorry guys, I didn't plan to do this. I didn't know I was going to do this today, so I didn't wear shorts. Right? So now flex and extend the hip. Feel how the muscles up top near the hip joint, they're firing a lot. They're bulging a lot. But the ones above the knee are not, they're not firing so much. You feel that?
Yeah.
It's the same muscle. It's the rectus femoris. But the top fibers have more action on the hip and the lower fibers have more action on the knee. Okay, now if you can, you may need to sit down for this. Now if you can, flex your hip so you feel the rectus femoris contracting. Flex your hip so you feel the rectus femoris contracting. And now extend your knee so you feel the lower rectus femoris contracting. You feel that?
Yes.
And you should feel fibers like in the middle contracting in a way that they do not if you keep the knee bent and you flex the hip. You feel the difference?
Yes.
Both the rectus femoris. Okay, does anybody not feel the difference? Okay, great. So now the vastus medialis and vastus lateralis. And if these are simple. You had your hand right here above the knee. So now simply move one hand toward the inside and take your other hand, bring it down and move it to the outside. All right. And now bend and extend the knee. And you should feel those muscles on the inside and the outside contracting. Vastus lateralis, vastus medialis. And while you're here, you might as well find your kneecap. Here's your kneecap. And above the kneecap, feel how there's a tendon. So I'm coming off of the border. Here's my kneecap. And I'm coming off of the border of the kneecap with my thumb up top, and I'm feeling there's a tendon there. It's better it's a little bit clearer if you do not flex your knee, if you extend your knee. There's a tendon up top. And then below the kneecap, there's a tendon down below. So this part of the tendon formed by the quadricep group, and this is the remainder of the tendon. It goes over the kneecap. This is called the pre-patellar tendon, and this one down below is called the patellar tendon.
Let's see.
I think we could spend easily 4 classes, 5 classes, maybe more, just on this, going through all the major muscles of the body. So, does anyone want to see any of that again? Does anyone feel unclear on the difference between the rectus femoris, flexing the hip, and the rectus femoris, extending the knee?
I don't know. I think that's pretty clear.
Okay, excellent. Excellent. All right. Let's just do a couple questions for this. All right, and then we're gonna move on. So we already went over all these muscles, but if you go to your presentation, you go to your slides, it will show you the tensor fascia lata. Oh, I'm sorry. This is a new muscle. They're not going to ask you this. It's called the tensor of the vastus intermedius. They're not going to ask you that. All right. It'll show you the vastus intermedius, which is kind of yellowed out. It's underneath the rectus femoris. So here's the rectus femoris. It goes, here's the rectus femoris. It's clearly visible, right? And here's the rectus femoris, a little bit obscured by the yellowing of the vastus intermedius. So you have the vastus intermedius deep, the rectus femoris shallow, and then you have the vastus medialis on the inside, the vastus lateralis on the outside. And I'm just gonna copy this image in case you guys want to take a look at that. We're almost done with the leg, and then we'll move on. Then we'll take a break. Sorry. Okay, just as a reminder, the hamstrings are made up of the biceps femoris and the semi-sisters, semimembranosus and semitendinosus. This is the back of the body. We know because if you look up here, you have the pubis. Okay, is this the front or the back of the pubis? I'm not sure yet. So let me look at other things. Here's the pubis. This is the femur. The features of this femur look a little bit like the back, but I'm still not sure. So I'm going to go down and look at the other bones. And then if I look at these bones, I don't see a patella. And also, this doesn't look like the front of the knee. This definitely is the back of the knee. And here's the fibula. So this is the lateral side, and this is the back side. And here's the pubis. All right, so this is the back, the posterior aspect. So these are the hamstring muscles. They always say there's the biceps that the biceps femoris has two heads. Let's see if it's on the next slide. I don't think it is. No, they say it has two heads, and I want you to see the second head is a small head that's deep underneath the big belly. So most of the bellies of the hamstrings, the three bellies of the hamstrings, biceps femoris and the semis, they attach to the pubis, or to the I'm sorry, not the pubis, to the ischial tuberosity. Here's the pubis more medially. Here's the ischium. And they attach to the ischium, the ischial tuberosity. Ischium on the bottom, ilium on the top. Okay, if we keep going, we find the muscles of the lower leg. Like I mentioned, there's the tibialis anterior in the front, which will function for ankle dorsiflexion, for foot dorsiflexion. On the inside is the soleus, and then the gastroc. On the outside is the peroneus muscle. You have the peroneus longus here, and then further down, not visible, you have the peroneus brevis. And then in between the peroneus and the tibialis anterior is the extensor digitorum longus, And here's a drawing from the side. So here's the fibula. Here's the bulge of the gastroc, or the belly, the gaster of the gastroc. Here's the tibialis anterior. So I know this is the front surface. This is the back surface. This is the side. Here's the peroneus longus. Here's the tibialis anterior, and wedged between them is the extensor digitorum longus. That, I think, is a bipennate muscle. Pennate or bipennate, extensor digitorum. Let's not guess. Extensor digitorum, pennate. A pennate muscle, yeah. Pennate muscle. Oh, and you can. How come this is not showing me the whole? I guess I gotta click like that, yeah. Extensor digitorum longus, it's very long, goes over the foot and attaches to toes 2 through 5, toes 2 through 5. All right, guys, I think you need a break. What do you think?
See.
Yeah, it's 12:15. Does anybody want to ask anything or clarify anything before we go? All right, so come back in 10 minutes. Come back at 12:25. 12:25.
Okay.
All right, see you in a little bit. Iliopsoas, yeah. So the hip flexor is a combination of the rectus femoris and the iliopsoas.
Okay.
Iliopsoas and hip flexor. That's what they asked her. And also the muscles of the anterior portion of the thighs and the posterior portion of the thighs. She wrote down anterior and posterior of the thighs. Of course, the thigh is only in the front and medial aspect, but I think what she meant was the hamstrings and the quads.
Okay.
Okay.
Easy.
Say that again.
So they just wanted to know the muscles for that.
I don't remember, or rather, she did not make a note of the specific question. But if you look at the anatomy, what you need to know is the anatomy, like you need to know where it attaches, and you need to know its action on the bones. Like, does it flex the femur? Does it extend the femur? Does it flex or extend the knee? In the case of the quads, or in the case of the rectus femoris and the 3 vastus muscles, right? And then you also need to know the basic. You also need to know the shape of the muscle, right? So if you go back to your learning, to your I want to use the correct terminology. If you go back to the FSMTB e-study guides, those guides come with study points, right? So the study points are what you need to know for all of them, right? So you need to know for the muscles, you need to know, look here, the shape or the fiber arrangement, the shape of the muscle. So is that parallel, or is it pennate, bipennate, or is it, convergent? And then you also need to know how it contracts, agonist, antagonist, synergist, prime mover. And then you also, I'm not finding it here. Let's see. Okay, locations of major muscles. You need to know the location. So that's mostly what we have focused on so far today. And then the attachment sites for the muscles, and then the actions of the muscles. So where is the rectus femoris? Is it in the front or the back? Is it a flexor? Is it an adductor? Is it an extensor? Is it an abductor, right? So where is it? What's the location? What does it do? What's the action? Is it a flexor, adductor, abductor, extensor? What's the action, right? So what, and more specifically, what does it do to the femur versus what does it do to the tibia? Or what does it do to the upper leg? What does it do to the lower leg? And then the attachment sites, there's small things that are, there's some details that are important, which I went over with you, and that is that the rectus femoris has a different attachment site, specifically an origin. Origin is the stable one, insertion is the more movable one. So it inserts, all these insert on the tibia. they insert on the femur and they insert on the tibia because they have fascial attachments all along the femur. But the origin is up here on the pelvis for the rectus femoris. And the origin for the vastus, the three vastus muscles are on the femur. So that's an important difference to know because that tells you that the rectus femoris moves the femur in the hip joint, it moves it, and that the vastus muscles do not. So you guys always go back to your study points, and those are in your MBLEx drive.
I wanted to ask a question in regards to the check marks.
Yes, let me finish.
do you-
They're in the they're under
Mhm.
FSMTB e-study guide, and then the 3 sections are there. I'll put the other 4 sections up. I'm sorry I haven't done that. I just regard them as easy to prepare for if you use a testing preparation app. I recommend the AMTA app for that. I'm sorry. Jessica. Jennifer, hello.
Hey, no, I just had a question in regards to the FSMTB study guides.
Yes.
Do you suggest that we just cover the study points that are in green, or should we be studying everything that's in the study guide?
Oh, this is a good question. You should study everything. The points in green. The points in green are the ones that we've covered in class. The ones that don't have green check marks, we haven't touched on.
Gotcha. Should be studying everything.
Yes, you have to prepare for everything.
Okay.
So
Confused on that. Okay.
yeah, let me just upload a new. So FSMTB anatomy and physiology. And just upload this new one and it'll have the updated green check marks. So this is a very good question. I did mention this in the beginning of class. However, I totally understand you not being able to remember that. Okay, I actually have to find my updated version. I won't spend time doing that, but for example, with the circulatory system, we covered almost everything except the major blood vessels, and then except the major blood vessels, we didn't really cover those. I just showed you like where the pulse points were. Carotid artery, femoral artery, others of this magnitude. Those are along the pulse points, right? But we covered the inferior, superior, and inferior vena cava. We covered the pulmonary artery, pulmonary vein, and we covered the aorta. But all these, just imagine all these have green check marks next to them. Okay, so all these study points are in your slides presentation labeled A&P, circulatory, respiratory. All those are in this presentation. All right. However, you are responsible for, or they may ask you, and you need to prepare for, everything in the anatomy and physiology module, which includes the circulatory system that we covered. It also includes stuff we didn't cover, like the digestive system. We'll cover a little bit today. The endocrine system, we covered, I think we covered all these: effects of massage, location of the endocrine glands, basic functions of each gland, more commonly discussed hormones, role of the hypothalamus and pituitary. Pretty sure we talked about all that. So these all should have check marks next to them. And then the integumentary system, the skin, we didn't go over that. So you have to go through each one of these. What are the layers of the skin? What's the function of the skin in the integumentary system? You know, it regulates temperature. It protects from pathogens and damage. It keeps the body hydrated. So it acts as a physical barrier and also as an immune mitigating barrier. Right? Understand the nerve supply of the skin, follow specific dermatomal patterns. So just be familiar with the dermatomes. I think we looked at the dermatomes yesterday. identify the appendages of the skin, like the hair, the nails, sudoriferous and sebaceous glands. So just look up each one of those. Hair, nails, sudoriferous and sebaceous glands, understand the effects of massage or bodywork on the skin. So, and then the lymphatic system, we haven't covered that, right? Here's the muscular system. We covered all the muscular system and I updated it with green check marks. The nervous system, this is not updated. We covered almost all of this, I think. I think we covered everything in the nervous system. Reproductive system, we haven't covered. Respiratory system, we covered only some things. I hope you guys are getting that with the amount of with the amount of information that they have on anatomy and physiology and the amount that they have in kinesiology alone, that those modules are big enough that that we can't do the whole thing in 5 weeks. We can't do the whole thing in 10 classes. Can't cover the whole exam. Can't be done. You guys need to give yourself, in my opinion, you need to give yourself 12 weeks total to study. So you've invested 5 weeks with me through varsity. By the way, I told them it's not long enough. You need to make it longer. I told them that 2 months ago.
Yeah, I wish they would, because
Yes.
I really schedule and I like how you're teaching it, and
Yes.
yeah, a lot.
Good. Well, you can either study with me privately, or you can go to the YouTube channel and you can, look up everything there. Like, as long as I have labeled things, you'll be able to find things easily. If it says,
Right.
class 4/23/23 unedited, that doesn't help you. But if it says class 4/23/23 muscles of the leg, bones of the pelvis, overview of SFMTB study guide, then you know specifically what's on there, right? Reported MBLEx questions, you know what's in there, and then there's chapter markers. So I'm sorry that I don't have time.
But you said study with you privately. What does that mean?
You can go to my, you can send me a message and we'll coordinate. I'm not allowed to actually,
Oh,
I'm not
okay.
allowed to actually discuss that, but
Okay.
there's 4 people here, and not all 4 of you are going to reach out saying, hey, how about studying privately? Okay, so for those of you who are not, let me just quickly walk you through the videos on the YouTube channel. So if you go to the YouTube channel, you see there is a, wait, let me do it this way instead. You can see there is a playlist. Okay, there's home, videos, shorts, playlists. If you go to playlist, there's the MBLEx, right? Okay, so if you guys go to, and if you click on the MBLEx playlist, view full playlist, you click on the MBLEx playlist, it lists all the videos that are there. There's 73 videos. Start with the most recently uploaded. All right. Look for the videos that have the dates of your classes. So look for April 23rd, April 22nd. So this is the 22nd. This is from yesterday. I notice it has no views and no likes. So this is from yesterday. All right. And then last week would have been, it's evil laughter, cold as ice. And then last week would have been the 15th and the 16th, I think. Right. So you look at those Saturday and Sunday, you make sure you go back and look at those. And if you have your notes, hopefully you have your notes with the dates on them. Get your notes out as you watch the video. And some of these videos have labels. So it's not just the date, it's the date plus what we cover. So this one, we cover the shoulder, all the muscles and the bones of the shoulder, right? This one is a 4-minute video from 319. It's a planes only. This is a short video from 319. It's joint movements only. This one is a short from 319. This is hamstring and hip flexors. There's a lot of shorts from 319. See 9 minutes, 11 minutes, 6 minutes, hamstrings, hip flexors, concentric, eccentric, circulation. If you go down, you find 319, 23 full. So this is all of them. This is all of the little chapters we just read. So you can see if you click on that, you go down and there should be, oh, there's no chapter markers. I'm so sorry. For some of them, there are chapter markers for some orientation terms. So we have, who do we know who goes, and for some of them there aren't. But I will do my best to get the videos labeled so it doesn't just say unlisted, unedited, okay, but it actually describes what's in the video, and at least that way you can scrub through it and you can find the different sections of the video, right? And that will be hopefully a helpful way to help you cover
Also
everything.
circumduction, right?
All right. But I think in your studying, what you really need to do is, and please like and subscribe and share these with anyone who you think can help them. What you really need to do is every day you need to open up 2 documents. You need to open up one of the e-study guides and then open up your basics. So MBLEx basics, which is down here. So the e-study guide, you just print out a copy for yourself or take a screenshot and mark it up, but look at it every day. And for yourself, check off the ones that you've studied. And you put the date, or you use a different color check mark or whatever, but you have to have a plan. You have to survey the whole battlefield before you head down there and start, breaking it up into manageable pieces that you can conquer. So you open up the FSMTB e-study guide for one of the modules, anatomy, physiology, or kinesiology, or patho, right? And you go through them one by one and ask yourself, okay, can I speak? Can I say the ways massage and bodywork might affect circulation? Can I describe the different blood vessels? All right, if I can't do that, if you can't do that, then you go back to your MBLEx. You go back to your MBLEx drive and you look at the notes. You don't need me to walk you through that, but
He says that.
hold on. So the first thing you do is you look at the study points and you kind of quiz yourself, right? You test yourself. What do I know? What do I not know? And that shows you what you're missing. Of these study points, which one are you missing? Okay, I understand the blood's role in healing, but I don't remember how oxygen is exchanged in the lungs versus the tissues. Or, you understand the major pulse points of the body, but you can find them, but you don't know the names of all of them. So I don't know the names carotid artery, femoral artery, and others, right? And if it just seems jumbled in your mind and disorganized, then go to the lecture, the ANP circulatory slides lecture, and read over it. If you want to watch the video instead, the video and the slides are the same. I use the slides presentation on the video. And the advantage of the video is you get to see me saying like, okay, touch here, find this bump, and then go a little inside, and that's the subclavian muscle or whatever, right? And you also get the benefit of listening. So you can listen to it in your car or, while you're on break or, whatever. What's your question? Was there a question? Sounded like maybe Jessica or Jennifer. Okay. All right. Okay, and that is for the first 3 sections. That's for ANP, kinesiology, and patho, right? So every day that you're ready to study, you go to your MBLEx drive, your MBLEx folder, and you open up one of the e-study guides, and you go in order. You do anatomy and physiology for like a few days until you've gone through all the sections, and then kinesiology for a few days till you've gone through all the sections, and then pathology for a few days till you've gone through all the sections. Then you go back again. right? You keep going through these 3 over and over and over again. Try to do like one every 3 days. Try to finish one section over like 3 or 4 days. That means you're studying like 3 sections of anatomy, 3 parts of 3 body systems in anatomy every day. You're doing circulatory system, then you're doing skin, and you're doing respiratory. You're doing those one day, and the next day you do the muscular system, which is huge, and then you do a smaller system. So you do like urinary system or reproductive system, right? And then the next day you do like the nervous system, which is pretty big. So you put something small with it, a smaller system like the immune system or the lymphatic system, right? So you budget as much time as you can, preferably first thing in the morning, and you go to your MBLEx drive, you open up an e-study guide, you quiz yourself, what do I know, what do I not know, and then you decide how you want to study. You either study from the slides presentation, or you listen to the video. Anything that to you seems like it's a big concept, you then go to your MBLEx basics and you look for it. Smartest thing for you to do would be to just hit Command A, copy the whole thing, Command C, copy the whole thing and put it into your own document and make your own. Right, but you can find the circulatory stuff, the summary of the circulatory information here, the flow of the blood, the small, from aorta down to arterioles and capillaries. You find the diagram of the heart, so you can practice the movement of blood in and out of the heart with all the structures. You find all the most pertinent information that I believe that they're going to ask you. Keep in mind, this is all what I think is going to show up. All the most pertinent information about I want to point specific, okay, I'll just use muscles, about muscles, like how they're organized, right? Different classification systems, functional versus morphological versus type, right? And then the shapes of the muscles, and then the different strengths of the muscles. Pennate muscles tire quickly, but they're very strong. Parallel muscles are very strong, but they tire quickly. No, parallel muscles are not very strong, but they have good endurance, right? Everything you need to know about joints, just so you can study in like an organized way, right? So you go from big amounts of time down to a small amount of time to drill. So you go in depth first by looking at the study guide and then looking at the slides presentation, right? This is like repeating a class. And then you go to the basics and you look for something to drill. Today I covered joints. Now I'm going to drill these 6 types of joints. Cover up the page, try to name the 6 joints. If you can't do it, just look at them and repeat them 3 times. Pivot joint, hinge joint, saddle joint, plane joint, ball and socket, condyloid. Then you question yourself, where's the pivot joint? Pivot joints are found in, I believe, the pivot joint is found, I believe, in the between the axis and the atlas on the skull, and then the radius is a pivot joint. And then we're on the hinge joints. Hinge joints are found in the elbow and then in the knee. Oh, I can't remember all the hinge joints. Let me go look that up. So maybe that's around here somewhere where all the hinge joints. Okay, hinge joints, ankle, elbow, and knee joints. Right. And if you don't find it here in your basics, then you go back to the lecture on joints. Or you can Google it, or you can watch the video. Okay, that's just for those 3. All right. And then in the last 15 minutes, the last 10 or 15 minutes of your study session every day, you take out your AMTA app and you pick one of the last 4 modules to go through. That's benefits and physiological effects of soft tissue manipulation, benefits and physiological effects of massage techniques, right? And then cautions is in patho. And then ethics and laws, guidelines for professional practice. And there's one I'm missing, and I can find it if I go to my MBLEx folder and go to the FSMTV, go to the MBLEx content outline. So you spend the last like 10-15 minutes studying just from the app, and you do benefits and physiological effects of soft tissue techniques, client assessment, reassessment, treatment planning, ethics, boundaries, laws, and then guidelines for professional practice. Once you've had a lecture and been walked through the benefits and physiological effects of soft tissue, and then, yeah, once you've been walked through this one, you can practice from the app. You have enough information in your memory, trust me, in order to practice from the app. And if something's really unclear, then you can look for it in the MBLEx folder, or you can Google it. But I have almost everything from this section in the MBLEx drive, located here in massage techniques. This sheets thing is a summary of all the massage techniques. And this is a summary like this is not the best way to learn. It's just a good way to see things really quickly if you want to see them quickly. Right, so it's there, and it's also in massage techniques. Oh no, this is the questions. Yeah, but this is fine. The AMTA massage techniques questions is completely fine to learn it that way. And there'll be a video lecture. There'll be a video lecture as well. So are you guys clear on how to study? Your study strategy is important. I think most of you have an idea about how to study, but some of you don't. Are there any questions about that?
I mean, I
I hope
think
you guys are-
that's it for me.
I will privately message you because I can't think of any right now, but
Well, I mean, if you want to set up private lessons, just message me individually. If you have a question about how to study or about some of the material, put it in the group, because
Okay.
someone else might have it.
okay.
All right. And there was another person speaking up. Was that you, Rosie?
No, that was me, Jennifer.
Jennifer, hi.
Yeah, no, I think you answered the question for me, because I was literally, I probably missed when you said that it was all of the study guides, but not just the green ones. Those were just the ones that you were checking. So thank you for that clarification, because I was just
Yes.
looking at the green. But no, I do understand that you have to either look at the videos and look elsewhere until you finally grasp the study points.
Yes, and the study points in green are all in this MBLEx
Mhm.
drive. They're all in the presentations, they're all in the videos, but we haven't covered everything. I think I need about another 3 months to flesh everything out in this way. See, I have been teaching the class using a different template. I was going over the questions from sites like YugoPrep and AMTA, and using those as the template for each section to try to narrow down which questions they're going to ask, right?
Mm.
But then when I purchased the FSMTB's preparation kit, that's when I found the e-study guide, and that's the most direct thing. I mean, I was using the content outline as like a broad e-study guide, as a broad study guide, but it's the e-study guide is so much more specific. And what I love about the e-study guide is that it tells you what you're not responsible for. You're not going to have to know, this aspect or that aspect, which is really good, because you need to eliminate some stuff right from the beginning. But everything that has a green check mark, and I will update it today. Everything that has a green check mark next to it also has a slides presentation, a video, and a lot of it is going to be in your MBLEx basics. Make a copy of this basics for yourself. You can't copy the document. You have to select all the information, copy it, and paste it into your own document. Okay. So let's go a little bit. I'm going to go a little bit over time. You guys can go over time with me or not. Let's do a few more of these questions, unless there are other issues you guys want to go over, other issues you want to address. Does anyone need a bio break? Bathroom break, bio break? Okay, remember to breathe. All right, so just out of curiosity, before we jump back in, what percentage of your friends would you say what percentage of your colleagues would you say have to retake the MBLEx? Is it half of them or a quarter of them? Or like,
For my class, it was a lot. Like, I think only 2, and it was like 6 of them that took it. Only 2 of them passed.
I see. Oh, wow. Okay.
I've been noticing that people aren't saying they've passed until for sure either the second time or the third time. I've been seeing like 3
Mhm.
times a lot more often, but I never see anyone pass it on the first try. And
Yeah.
I've taken it once already too. And yeah, I really failed it bad. So I was like, whoa, I thought I knew more than that.
Yeah. Every class is different, but you guys are sharper than most. So I am surprised to hear that that it's been challenging for you guys. So the stats on the MBLEx, the official FSMTB statistics are that over 70% pass their first try. So if there's a discrepancy between what you're seeing in your community and what the FSMTB reports, if the FSMTB is accurate, then that means that you guys were not prepared, like your whole
Yeah.
community.
I think we were.
Not at all. I was
Yeah.
so like shocked. It was
Right.
just such a shock. I was just like, when, what?
Yeah,
Okay.
I mean, same here. I was completely thrown off. I thought I was gonna cram and pass. I thought it was easy.
Me
and it's-
too. I already had my lady book. I had 2
Yeah, UGO
muscles book, and then I bought another book towards questions for all subjects for 2023. And I was
Yeah.
going over that, and even that, the questions, just how it like described things, like it still wasn't like hitting. I think maybe 5 of those questions were actually like on the test, just reworded differently.
Yeah.
But
Right.
it was just nothing like it.
Yeah.
The thing about studying from the thing about the structure of a question is that there's so many different ways to word it, that the only way really to reliably answer it is to know the actual anatomy, the actual
Mhm.
physiology, the actual kinesiology.
Yeah.
Like you have to actually understand the body in order to answer the question.
Mhm.
For those first 3 sections, it's not about studying as many questions as possible. The preparation sites will tell you straight up that, well, not straight up. The preparation sites will tell you the best way for you to prepare is to have a collection of as many questions as possible. And our site has the most questions. That's what they'll tell you. But
So you're saying that just reading a question, that's not really proper. Like we have to go into the systems and know way more thorough than that.
yes, and in order for you to know it thoroughly, you can't just look at it on the page, right? You have to hear yourself saying the names, and you have to touch the structures when you can, or you have to move the body, or you have to think about, when you eat fat, the gallbladder does this, the pancreas does that, right? You have to actually put things that you can't touch, feel, and move. You have to put it in the context of your everyday experience.
I see.
You can't just think about the words on the page, but when you sit for the MBLEx, that's all you have. You have the words on the page, which is really pretty abstract. So you need the experience of kinesthetic learning behind you, and the experience of like putting yourself in the context of a daily experience. You need that behind you.
Okay.
Yeah, I think when I took the test, I know for sure that I did really good on the boundaries, the ethics, the professional practice, and the client assessment, just because I've been a counselor for 3 years.
Great.
So
Great.
that's like literally the parts that helped me for things that I do know.
Yeah.
But everything else that we're learning in class is like what I actually needed help with.
Yeah. Okay. Well, I for those of you who haven't had clinical experience before, in my opinion, those 3 sections are not difficult to master, to prepare for the MBLEx. But those are the ones you do need to do the questions regularly. So make sure you're going through that app, going through the AMT app and doing as many of those questions as possible every day. Every day.
Like
Oh.
A&P and kinesiology is the hardest, especially
Yeah.
kinesiology. Like I feel like everything else is pretty much a breeze.
That's
And
great.
I haven't took the test at all. Like I graduated a long time ago, in like 2016.
Yeah.
And I never took the test. Like after school, like my mom passed, and then like I just did like a whole shutdown. So
I'm
like
sorry to hear
I
that.
just, and then I just, as the years went on, I'm like, no, I need to get back into, what I wanted to do. So that's why
Yeah.
I'm here. And yeah.
Yeah.
That's it.
Yeah. Well, that is definitely a familiar story. I think we all have had something like that happen for sure. Life kind of telling you, no, you're not going to do this right now. You got to take care of this other stuff. So, but I think that from start to finish, when you're ready to dedicate time every day, 6 days a week, because you need one day to let your brain rest and integrate everything, associate everything. When you're ready to dedicate time every day, 6 days a week to studying, I think you need 12 weeks. And if you listen to most people who failed and know other people, they'll tell you that they needed 2 or 3 tries in order to pass. So, and they make you wait, like, how long do they make you wait between exams?
30 days. I took it 3 times and failed each time.
30 days. So January 1st to February 1st to March 1st, that's 30 days. That's 90 days right there. That's 12 weeks right there. Right. So instead of paying for the exam a second, third time, if you've only taken it once, set aside 12 weeks and study for it. It's the same amount of time, and you actually will be prepared.
Right.
Unfortunately, what I'm seeing is that a lot of massage schools, and my program too, my acupuncture school too, they are not preparing us with the level of A&P and kinesio that we really need. And it hurts us clinically as well. It's not easy to solve someone's hip flexor pain if you don't know which muscles attach, which muscles make up the hip flexor, right? And then after that, you have to understand why those muscles are getting cranky, which is a whole other discussion. None of that stuff is difficult. After more than 15 years of practice, I can tell you none of that stuff is difficult, but it's not clearly organized anywhere for you and put out there. People don't organize, the 4 or 5 different types of back pain, the 2-3 causes of hip flexor pain, hip flexor snapping, and a basic approach to each. But which is why it takes time to learn all that stuff. The saying is, ars longa vita brevis. The art of medicine is long and life is short in comparison. So, and you are practicing medicine, you are practicing physical medicine. However, if you can see everything before you train for battle, if you can see everything and you know what possibly could be asked, you can prepare for everything, right? So again, every day, test yourself, like look at the landscape, go to your e-study guides, pick one module, do anatomy and physiology, kinesiology, or pathology, pick one module and focus on that for like 1 week, 3 days, whatever you can do. And then quiz yourself first, just spend a few minutes quizzing yourself. Do I know this aspect? Do I know this study point? Do I know that study point? And if it feels like you've mastered all the study points for that system, move on to the next one. If it feels like you're not getting enough of it, then go back to a slides presentation or a lecture. Play your lectures in your car or while you're on break. And then after you do that, you spend your last 10 minutes studying from the AMTA app for the latter 4 sections. And if you cycle through like that after 12 weeks, you'll be pretty good. Don't forget, when you're looking at something, you have to be moving and touching wherever you can. You have to be imagining literally chewing up and swallowing that piece of food and it going down into the stomach, and then the liver and gallbladder being stimulated. You have to imagine those kinds of things with that sort of thing. All right. So guys, please be on the lookout on my YouTube channel over the next couple months, because there are some videos that I'm going to add that people from other sections have requested, and some things that I think are important. Like, I'm going to make a video on all the major muscles, just on the movements, like how they move things, right? And then it'll be similar to the agonist, antagonist, concentric, eccentric video that I put up there recently. But massage students really feel like they do not know the muscles well enough, the major muscles. So I'm going to make one just so people can practice the movements and understand the differences between, you know, which muscle does which movement and which muscle does another one. And then I'll make other videos on sections, being very specific about attachments, shape, also the action, but attachments, shape, and then tricks on how to remember the muscles, right? And also the bony features. Knowing the bony features will help. I don't think they're going to ask you about tons of the bony features on the MBLEx. I haven't seen practice. I say that because I haven't seen practice questions like that. But for example, this bump here where the rectus femoris attaches is called the anterior inferior iliac spine. And this is the anterior superior iliac spine. I don't think they're going to ask you which of the anterior iliac spines does the rectus femoris attach to, superior or inferior. I haven't seen that. And I think that's kind of a deeper level of questioning that I don't think they're going to go there with you. Speak up if you've seen that kind of question. All right. So keep your eye out, and keep your eye out for new uploads on the YouTube channel, and also for like updating the titles. I will try to send you guys a message when I upload something, but I can't guarantee. And if anybody wants to be taken off of the group chat, just let me know to take you off. All right, so let's continue. So some of the other questions were about the functions of the digestive system. Specifically, the question my student remembered was bile. What organ produces bile? The answer is the gallbladder. And it always helps with the internal organs to understand their location relative to the other organs and what they do. It gives you a little bit more visual context, because it's really difficult for us to touch those things. Now, you can touch the gallbladder and liver if you want to try. You simply go to the bottom of your rib cage and you go over on the right side and you stick your fingers under your ribs. Exhale as you do it, because it'll make it easier. And then take a deep breath. And you may feel your liver poking into your fingers. So the liver and gallbladder are down in that area. Hopefully that gives you a little kinesthetic aspect. And if you look at the diagram, the gallbladder is tucked behind or underneath the liver. So here's the liver, and you can see this faint outline of the gallbladder back here. It's like the shape of the gallbladder at this point without the tubes is kind of like a cone, or like I don't know what this shape would be called, looks like a squash, to be honest. So the gallbladder is a small sac. Its job is to store bile. It stores bile. The liver produces the bile, and the gallbladder stores it. If you look at the liver, it has these bile ducts, and the purpose of the bile duct comes from the liver, comes from the two branches of the liver. The purpose of the bile duct is to collect bile and to bring it down, and it goes into the gallbladder where it is stored. The gallbladder is a muscular sac which squeezes, and you can see that there are these different what are these called? I'm sorry. Veins also have them. There are let's see, arteries have have muscles, and veins have, just a minute. Oops. Veins have valves. Veins have valves. The gallbladder also has valves. And the purpose of the valves is to send the bile into the gallbladder. You don't need to know that it has valves, but just so you understand, it sends the bile one way into the gallbladder, which stores it. When the gallbladder squeezes, the pressure of that squeeze pushes the bile back against the valves and forces it out through the cystic duct. Cyst also refers to gallbladder, and it pushes it into the small intestine. I doubt they're going to ask you whether the bile goes into the small intestine versus the stomach or whatever, right? But just so you know, the gallbladder squeezes the bile through its duct, and that goes into the small intestine. Same thing with the pancreas. The pancreas squeezes pancreatic juices into the small intestine. Here's the stomach, and here's the small intestine. This is called the is that the jejunum or the duodenum? I remember it by DJI, like DJ Ilium. So let's see. So parts of small intestine. Parts of small intestine. The duodenum is first, the jejunum is second, and the ileum is last. So I really can just trust my own. Yeah, the duodenum is first. Here's the small intestine in green. Duodenum is first, the jejunum is second, and then the ileum is the last part before it joins the large intestine. Food goes from the stomach into the duodenum, into the small intestine, duodenum, jejunum, ileum, DJ ileum, you know, like a DJ ileum. And then from the small intestine into the large intestine, ascending colon, transverse colon, descending colon, rectum, anus. So from the stomach into the duodenum, DJ ileum, and it's the duodenum that receives the bile and the pancreatic juices. So it's the gallbladder that stores the bile. We don't have much phrasing. What organ is bile? If they say what organ is responsible for bile, what organ secretes bile, secretes is probably a word that they would use. The answer would be the gallbladder. Let's just see in the FSMTB questions. If you go to the FSMTB MBLEx 100 question practice exam, these are all the questions from the site. Gallbladder. Oops, gallbladder. No, there's no gallbladder question here. Okay. All right, unfortunately, there's no gallbladder question available on the practice exam. But that's the gallbladder. The liver makes the bile, the gallbladder stores it, the gallbladder secretes it or squeezes it into the duodenum. Also squeezed into the duodenum, secreted into the duodenum are the pancreatic juices. Function of the bile is to emulsify fat. It emulsifies fat. Bile makes fat soft, breaks it down into smaller portions. Okay. Yeah, here's just another visual. Small intestine has three parts: the duodenum, the jejunum, and the ileum. It helps to further digest food. This is its function. We're getting into the function part of the FSMTB. So if you look at the anatomy and physiology section, come on. If you look at anatomy and physiology and you go down to the digestive system, it's know the location and the structures of the digestive system, which we just covered, right? Understand the functions of the parts of the GI tract, what is processed and what is absorbed at each portion. For example, water and mineral absorption from the large intestine versus the majority of nutrients, including fat, in the small intestine. I'll say that again. And then understand the path of consumed food through the digestive system, which is the same as the structure of the digestive system. Understand how the accessory organs are involved, such as the liver, gallbladder, and pancreas. So we're looking at the functions of the small intestine. All right. Looks like, yeah. So the function of the small intestine is to continue digestion, and mainly it absorbs nutrients. That's mainly what it does. It absorbs nutrients. The stomach, for the most part, breaks food down, and the small intestine, for the most part, absorbs nutrients, especially vitamins, minerals, carbohydrates, fats. I don't get this annoying. There it goes. Fats and proteins, and also water. Carbs, fats, proteins, water, vitamins, minerals, that's everything in our food. All right, and then the stomach, we already said, mainly its function is to break food down. And then we have the large intestine. The large intestine doesn't so much do breaking food down, and it doesn't absorb so much nutrients because the function of the large intestine is not to break stuff down. That's the function of the stomach, and to a lesser degree the small intestine. But the large intestine absorbs the last remnants of our food, so that's a lot of water. It makes sure that we get hydrated, and also takes out salts. There's many kinds of salts from the material that hasn't been digested, and then it gets rid of waste. So it is like the most toxic part of the body, because it deals with the waste. But we need part of our body that will do that, right? Okay, moving on. So now there are questions about codes of ethics. So this is the last time I'll refer to this summary. I'm just going to keep going through the slides. So questions about ethics, scope of practice, transference, countertransference, we're going to move into those now. So ethics, if they're definitely going to ask you ethics, they're going to ask you what is the scope of practice, they're going to ask you the difference between ethics and scope, right? And what you should tell, what you should say is that ethics is a set of rules or principles about good behavior. So it's about behavior, it's morals. If you violate the code of ethics, that's an ethics violation. That's just the term, okay? Ethics, the difference between ethics and scope is that the scope refers to activities that you're licensed to do. So think of your scope as based in law, and think of ethics as based in morality. That's kind of an easy way to remember it. Hold on a second, please. Ethics are based in morality, and scope is based in law. Ethics regulate bad behavior, or they provide a guideline for bad behavior, good behavior. I'm sorry, not just bad behavior, bad and good behavior. Scope of practice is what you're licensed to do, refers to all the activities you're licensed to practice. That's from the American Medical Association definition, just so you know I'm not making it up. All right, and then I put these two slides in here just to talk before I move into like systemic and local contraindications, which we covered, I think, yesterday or maybe last week. Some of the summary information and what you're not responsible for knowing. So important implications of pathological changes in the body, protecting the client from harm, knowing how and when not to treat are essential for safe practice. Understanding the ways in which pathological changes affect the body's ability to accept massage and bodywork treatment, and recognizing the signs and symptoms of common pathologies to help you identify contraindications and understand the best way to proceed when presented with pathological changes in the body. And then contraindications are understand the difference between local and systemic, identify when certain types of treatment are contraindicated, like when do you not do tapotement? You know, for example, you don't do tapotement on the sacrum or the back of someone who's pregnant. You wouldn't do it then, right? When would you not do something on skin that is irritated? Any kind of irritation where even if there's not broken skin, you wouldn't apply hot stones, you wouldn't apply ice packs or hydrocollator packs. You also wouldn't do, you probably wouldn't do massage at all on irritated skin. But if you're concerned about breaking the skin down, if the skin is especially thin due to like neuropathy or something of that nature that's affecting the skin, you wouldn't do things that involve friction. You might do some shallow compression, for example. Recognize major contraindications like fever. Fever is a total contraindication. Acute infectious disease, inflammation. So moving on, just reminding you that the systemic and local contraindications means the systemic means the whole system or the whole body. Do not massage the person at all. Systemic is a total contraindication. Fever, infection, deep vein thrombosis. Those things are all systemic contraindications. Over-medicated, under-medicated, no availability of insulin that day for someone who's diabetic, systemic contraindication. Local contraindications are one area you can massage the person, but stay away from the area. So a sunburn on the back, stay away from the back surface, right? A broken bone, stay away from that limb or that area. I'm going to move on because I think we did this yesterday. Let's just go over these. So in general, when you think about local contraindications, it's one area, and think about the fact that it needs to be left alone in order for it to heal. That's definitely any kind of open skin, any kind of like local infection, local meaning like on the skin, on the foot, on the hand, on the face, whatever. Any kind of skin damage. It also includes these items. So the first three are all circulatory. So that's an aneurysm, varicose veins, phlebitis. You don't massage over varicose veins. If someone has phlebitis or has had an aneurysm, you don't work in that area. And then other things, neuropathy. So neuro means nerve, pathy means diseased state, or you could think of it as kind of an abnormal state. So numbness, tingling, lack of feeling, lack of sensation, those are neuropathy. Sometimes you can have pain with neuropathy. Diabetics have that a lot. Muscle tears, any muscle that's torn, don't massage the tendon of the muscle, don't massage the muscle group. Bruising, fracture, pregnancy, that's a local contraindication. Definitely go get your continuing education for prenatal. You will serve your community times 10, I promise you. Any undiagnosed stuff like undiagnosed lumps, undiagnosed pain, inflammation, including arthritis, and rheumatoid arthritis, which is an autoimmune disease. All right. Always get medical clearance, get a doctor's approval with cardiovascular conditions, any kind of cardiovascular condition, any condition already being treated by a medical practitioner. Somebody comes in and you find out through your questioning, through your exam, or they volunteer. I'm being treated right now for high blood pressure. Always get a doctor's note, right? Cover yourself. They come in and they say, I'm being treated for anxiety right now. I take Lexapro for anxiety. You don't need to get a note for that. If they say I have severe anxiety, sometimes I go to the hospital, and for that I'm taking this drug, or I'm taking a combination of drugs. If it sounds severe, yes, get a note for that. In the meantime, be with them in the room, do some nice aromatherapy for them, charge them, do half the session, charge them half the price, be very gracious and appreciative, and rebook them for the next time. And ask them and mention that you want a referral. Edema, osteoporosis, cancer, heart problems, epilepsy, diabetes. Okay, now we're going to talk about sprains, strains, and trigger points. We did these yesterday, so I'm actually not going to go over those. Somatic versus referred pain. Those are in your patho lecture. Also in your patho lecture. Okay, transference versus countertransference. So let's say I am the client and you are the massage therapist. if the client starts asking you personal questions, wants to get closer to you personally, starts to personalize his or her relationship with you, that is called transference. If you start to get curious about the client, you want to know more about the client, get closer to the client, you want to personalize your relationship with the client, that's called counter transference. That is an ethics violation. Do not participate. How are you going to remember transferences from the client to the practitioner and counter transferences from the practitioner to the client? Well, the way that I remember it, and this is stuff that I have to, I need systems in place to remember stuff like this. So what I remember is that the client comes first. So transference comes first, like verbally, because you can't have counter transference unless you have transference, right? So you can't, in an argument, make a counterpoint unless someone has made a point. You cannot, in a boxing match, you cannot have a counterattack unless you have an attack, right? You can't counter unless someone has done something first. So the transference is the first thing that verbally comes, right? And we always put the client first. So the client is first, transference is first. The practitioner comes second. The focus on us is after the focus on the client. So the practitioner comes second, counter transference comes second. So hopefully you guys remember that. Hopefully that makes sense to you. Any questions about that? The client comes first, so transference is from client to practitioner. The practitioner comes second, so counter transference is from the practitioner to the client. I want to share with you guys that somebody close to me recently got a massage, and the massage practitioner touched her vagina several times, just as a like accessory movement to palpating her adductors. And we are just now starting to unpack the depth to which that aggression is affecting her. So it affects people on more than one level. So you keep that in mind. Like, you will have clients who try to personalize and try to get you to cross boundaries in the most egregious ways. You will have males, females, all individuals. You'll have all individuals attempt this, and they will sweeten the deal either by offering you money or by offering you, whatever, right? But the damage that does is not something you can estimate in the time. It is significant enough that it continues for a long period of time and requires significant work to heal from. So, our professions get a lot of disrespect, but you guys have it worse because as massage therapists, everybody says you give happy endings, right? You're sex workers. And there is nothing wrong with sex work, which is a separate kind of discussion about my politics and all that, but nothing wrong with sex work. But if you're not a sex worker and that hasn't been agreed to by both people, venturing across that boundary causes significant damage, severe damage. So stay away from it on both ends. Don't perpetrate. Also, do not participate if asked, and you will be asked. Okay, so moving on. Which movement will lengthen the fibers of the quadratus lumborum on the right side of the body? The right side, quadratus lumborum. That's in the back. Which one will lengthen the quadratus lumborum? Is it going to be hip elevation, lateral flexion to the right, lateral flexion to the left, or extension of the vertebral column? Which one is that going to be? What do you guys think? Lengthen quadratus lumborum. It has to be one of the flexions. So if it's the right quadratus lumborum, it's going to be lateral flexion to the left, towards left side. So the right side is opening. Lateral flexion towards left. you guys have to be the ones in the MBLEx going like this. Okay, my QL is back here, right? And then you have to be going like this: left flexion, right flexion, hip extension, right? Extension of the vertebral column, hip elevation, right? By the way, what does hip elevation mean? It's not specific enough. Elevating the hip, it doesn't say left or right. Also, elevation is not usually a term we use to describe the movement of the hip. We would say, would we say elevate the hip? I guess we could say elevate the hip. Sure, okay, elevate the hip. I would say close your side waist, right? Depress the ribs, bring your ribs towards your hip. Maybe I'm wrong about that. Okay, HIPAA, 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 Health Information Portability Accountability Act. Health information. The HIPAA stands for what? Health Insurance Portability and Accountability Act, Health Information Portability and Accountability Act, Health Information Portability and Assurance, Health Insurance Portability. It's health information. Is it information or insurance? Hold on a second. Health Insurance, not information. Health Insurance Portability and Accountability Act. Let me double check that, because Health Insurance Portability and Accountability Act, Health Insurance Portability and Accountability Act. But health insurance encompasses health information. So information is contained in somebody's insurance information, because their insurance collects information about their health, right? Pre-existing conditions, things they've been treated for, outcomes. Okay, I think that's it for the HIPAA, or that's it for the presentation that I have available to you. There's other stuff in here which we haven't covered today. I'm just gonna cover one more thing because it's kind of confusing, and it's in your MBLEx basics. That's force stability or dynamic stability, form stability, also called passive stability. So if you go to your MBLEx basics and you do like Command F for find, and you put in like stability, you find this explanation right here. So force stability or dynamic stability, when you hear dynamic, you think movement. When you hear movement, you think muscles and joints, right? So dynamic stability is provided by muscles contracting. So I'm able to keep my neck from side flexing by using the muscles on either side of my neck and the ones in the front and the back. So that's muscular force. So that's force stability or dynamic stability. But my spine has like a longitudinal shape, longitudinal integrity, just from the way the bones are lined up. That's form stability. So passive stability, my skull should be able to sit on top of my vertebral column and be stable to an extent without movement. And that's called form stability or passive stability. That's the bones and the ligaments that hold the bones together. Remember, ligaments hold bones and tendons hold muscles to bones. So that's the last thing I'll cover. Okay, guys. Feel free to reach out to me anytime with questions. I'm still getting my whole MBLEx package together, still refining it. I think I'm about 70% of the way there, which is pretty damn good, but I'm still getting things together, and there's, it's an investigative process. So if you have any questions, it might help me to understand what people come out of the schools missing and what I need to prepare people on. If you can remember any of the questions from the exams, please write those down and send them to me. Feel free to put them in the group chat because it'll benefit everybody. It's not cheating. Cheating would be like, the answer to this question is this one. The answer to this question is that one. Anyway. Okay, guys, thanks a lot for your time and for your patience. I appreciate your willingness to let me reschedule 2 of these sessions. This is the makeup for number 8. Yesterday was makeup for number 7. So thank you very much for being understanding with that. I'm grateful that we all could make it. Please stay in touch. Please watch the YouTube. Let me know if you want to be removed from the chat. Let me know if you have any questions. Also, if you have any feedback about the course, anything that didn't work for you the way that I did it, it will help me to improve. It'll help other people. So please send those along. Guys, enjoy the rest of your day, and I'll be hearing from you soon. Okay,
Okay, thank you.
Right.
Bye.
Have a good one.
All right.
take care. Bye-bye.
Yeah, you too.
Good luck, everybody.
Thank you.
Bye.